The posterior pituitary gland is also known as the neurohypophysis. It does not produce any hormones. Its only function is to provide storage for two hypothalamic hormones called antidiuretic hormone and oxytocin. Oxytocin and antidiuretic hormone are produced by hypothalamic secretory neurons of the supraoptic and paraventricular nuclei. These hormones travel down the infundibulum in unmyelinated C fibers of magnocellular neurons from the hypothalamus to the posterior pituitary. There, the hormones are stored until stimulated for release. Diuretic hormone is also known as vasopressin. It is a polypeptide. The different names refer to the different functions of the hormone. Antidiuretic hormone affects blood volume, whereas vasopressin affects blood pressure. Plus, the different names also refer to the different second messenger systems used to stimulate the target tissue. Antidiuretic hormone uses cyclic AMP second messenger system to activate epithelial cells of the kidney, and vasopressin uses phospholipase C second messenger system to activate vascular smooth muscle. Antidiuretic hormone stimulates the kidneys to reabsorb water. Without antidiuretic hormone, collecting ducts are virtually impermeable to water. ADH binds to aquaporin transport proteins located within the cell membrane of epithelial tissue that form the collecting ducts in the kidneys. ADH is the main stimulus for removing water from the filtrate and putting it back into the blood. It's even more important than aldosterone, plus it doesn't require the kidneys to exchange any ions to reabsorb water. ADH is essential for preventing dehydration by maintaining the water-salt balance in the body and in cellular fluids. The function of vasopressin is to cause vasoconstriction, which will increase blood pressure. Blood volume is directly proportional to blood pressure. If blood volume is low, that means body fluids are low. So when the hormone ADH/vasopressin is released, the ADH function will increase body fluids by acting on the kidneys, and vasopressin's function will act on smooth muscle of arterial blood vessels to increase blood pressure. It's just like squeezing the lumen of a garden hose will increase water pressure. Decreasing the lumen of an arterial vessel will increase blood pressure. Composition of blood. The main point I want to make with this slide is that blood is mostly water, and I want you to appreciate the normal relationship between the amount of stuff in blood and the amount of water in blood. If blood has more stuff than water, it's considered dilute. Normally functioning kidneys will remove the excess water, restoring the normal balance. If blood has more stuff than water, it is thick. The kidneys, under the influence of ADH, will reabsorb water out of the filtrate, put it back in the blood, restoring the normal balance. You don't need to memorize the percentage of the elements in the blood. I won't be testing you on that portion. Hypothalamic stimulation of ADH release. The hypothalamus monitors solute concentration of blood via osmoreceptors as a part of homeostasis. Throughout the day, the solute to water ratio changes based on the amount and type of food one eats, and the amount and type of fluid one drinks, and the amount one perspires. In fact, our thirst mechanism is activated when the ratio of solids to water shifts to more solids than water. A high solute concentration of blood stimulates the hypothalamus to signal the posterior pituitary to release ADH. And a low solute concentration of blood will inhibit the release of ADH. Do you remember when we covered the 3 types of stimuli that cause the release of hormones in the PowerPoint Introduction to Endocrine lecture? Well, ADH release is an example of humoral stimuli. Heart and carotid artery stimulation of ADH/vasopressin. Stretch receptors in the heart monitor blood volume. If blood volume drops, the heart will signal the hypothalamus to have the posterior pituitary release antidiuretic hormone. Baroreceptors in the carotid artery monitor blood pressure. If blood pressure drops, the baroreceptors in the carotid artery will signal the hypothalamus to have the posterior pituitary release vasopressin. Both the heart and the carotid artery are using humoral stimuli to maintain homeostasis or respond to acute situation. This system is not engaged with chronic low blood pressure or chronic low blood volume. Mechanism stimulating or inhibiting secretion of ADH/vasopressin by the heart and carotid artery. When atria stretch receptors are excited by overfilling as a result of normal or excessive blood volume, they send signals to the hypothalamus to inhibit ADH secretion. If the stretch receptors in the atria are not excited as a result of underfilling, they will send signals to the hypothalamus to have the posterior pituitary release ADH. When baroreceptors in the carotid arteries are excited by high blood pressure, they inhibit vasopressin secretion. However, if the carotid artery baroreceptors are not excited due to low pressure, they send signals to the hypothalamus to have the posterior pituitary secrete vasopressin. Without ADH, the kidneys cannot reabsorb adequate amounts of water without the help of ADH. As I mentioned previously, the collecting tubules are basically impermeable to water, and aldosterone alone is not enough to maintain the water-solute balance, mostly because aldosterone is pretty specific only for maintaining water, sodium, potassium balance, and as I showed you in the slide about the composition of blood, solutes in blood make up a lot of stuff and not just sodium and potassium. Without adequate amounts of or adequate response to ADH, urine will be too diluted, causing dehydration of body fluids. When extracellular and intracellular fluids decrease, cellular processes cannot function. Without adequate amounts of fluid, blood becomes thick. Blood volume is decreased and blood pressure decreases. Some symptoms associated with decreased level of ADH or lack of response to ADH are increased thirst, polyuria, which is frequent urination, and severe headache. These symptoms are very similar to early onset diabetes. Well, there is a type of diabetes associated with inadequate ADH release or inadequate response to ADH that I'll talk about in the next slide. Diabetes insipidus is a condition caused by hyposecretion of antidiuretic hormone or abnormal response to antidiuretic hormone. It can be the result of a trauma to the hypothalamus or posterior pituitary or a congenital lack of ADH receptors or unresponsive receptors. Diabetes insipidus can be life-threatening without diligent water intake or synthetic antidiuretic hormone medication. Oxytocin is a polypeptide hormone that utilizes the phospholipase C second messenger system to stimulate its target cells. It is one of the rare hormones that operates on a positive feedback system. One example that I used previously in the Introduction to Endocrine lecture is the role of oxytocin in the birth of a baby. Oxytocin powerfully stimulates contraction of the pregnant uterus. The greater the distension of the cervix, caused by the baby's head pressing against it, stimulates the release of more oxytocin, which creates a greater contractile force. Oxytocin has an important role in lactation. The hormone causes milk to be expressed from the alveoli into the milk ducts of the female breasts. Secretion is stimulated by the baby suckling. A mother can continue to produce milk as long as the baby continues to suckle regularly. A couple of other terms used for the effect of oxytocin is lactating breast. It's called milk letdown or milk ejection. I just want to be clear that oxytocin does not stimulate milk production. It just stimulates the milk letdown or release. Growth hormone is also known as somatotropin. It is produced by anterior pituitary somatotropic cells. Growth hormone affects all or almost all tissues of the body directly. Growth hormone does not stimulate other endocrine glands to produce hormones, but it can stimulate them to grow in size or regenerate depending on one's age. The major target tissues of growth hormone are bone and skeletal muscle. But I will reiterate, it can cause growth of almost all body tissues capable of growth. Growth hormone secretion. The synthesis and secretion of growth hormone is controlled by the hypothalamus releasing growth hormone releasing hormone. Secretion of growth hormone is subject to negative feedback to the hypothalamus and anterior pituitary. The amount of growth hormone secretion is also influenced by sex hormones, estrogen, and testosterone during adolescence. They are considered facilitatory to growth hormone. Once secreted into the blood, growth hormone does not circulate very long, only about 20 minutes. It rapidly leaves the blood to stimulate the target tissues by binding with receptors on their cell membranes. Growth hormone is produced and secreted throughout one's lifetime. However, the amount gradually decreases over time, and by the geriatric stage of life, growth hormone secretion is about 25% of the level secreted during adolescence. Growth hormone is regularly secreted on a daily circadian rhythm, typically during the first 2 hours of deep sleep. Here it states that growth hormone is released on a pulsating pattern. I need to let you know that most, if not all, hormones are secreted on a pulsating pattern, meaning the endocrine gland does not just dump the total amount of the hormone it's supposed to release into the system at one time. Well, unless there's a pathology that happens. We'll talk about that with thyroid hormone. Endocrine glands release their products little by little. In addition to growth hormone being released every 24 hours, strenuous exercise can also stimulate the hypothalamus to release growth hormone releasing hormone, which will then stimulate the anterior pituitary to release additional growth hormone. There are two abnormal conditions that stimulate the secretion of growth hormone: hypoglycemia and long-term decreased dietary protein. Hypoglycemia is the strongest acute stimulator of growth hormone secretion, and long-term decreased dietary protein, as in the case of Kwashiorkor, is the strongest chronic stimulator of growth hormone secretion. Notice the white line of hair growth in this photo? It does not represent a new fashion trend. It is a sign of about 2 months of severe protein deficiency. Individuals suffering with severe protein deficiency will stop producing melanin in their hair follicles. Growth hormone increases protein synthesis while decreasing protein catabolism. One of the primary effects of growth hormone is to increase protein synthesis. Tissues need more protein to grow. The main way growth hormone stimulates protein synthesis is by enhancing the transport of amino acids into cells. Cells, and therefore tissues, need amino acids to produce proteins, and increased production of proteins will lead to tissue growth. The increase of intracellular amino acids will stimulate DNA transcription. Increased transcription will produce an abundance of mRNA. In order for the cell to manage all this extra mRNA, the cell will have to increase the activity and the number of ribosomes to handle this big load of mRNA. Growth hormone also decreases proteolysis, so it's also known as a protein sparer. Growth hormone increases serum glucose. Another interesting effect growth hormone has on the body is that it increases serum glucose levels. It does this in two ways. One is by attaching to GLUT4 transport proteins in skeletal muscle and adipocytes. This attachment prevents the GLUT4 transport proteins from merging with the membrane on skeletal muscle and adipose tissue. Without the function of GLUT4 transport proteins, skeletal muscle and adipose cannot take in very much glucose, thereby increasing serum glucose. This decrease of intracellular glucose in skeletal muscle and adipose tissue will ultimately decrease glycolysis in those tissues. and they will resort to another method to produce energy. Another way growth hormone increases serum glucose is by promoting liver gluconeogenesis. Glucose production by the liver is short-term, though, because the overall increase in serum glucose will eventually stimulate insulin secretion. Insulin will also stimulate the cells to take up amino acids, thereby enhancing and or prolonging the protein synthesis effect of growth hormone, but it will also inhibit the liver from synthesizing glucose. Growth hormone is considered diabetogenic because its normal effect of increasing serum glucose. Normal levels of growth hormone are not a problem. However, abnormally high secretion of growth hormone could lead to type 2 diabetic-like conditions known as pituitary diabetes, such as too much serum glucose and insensitivity to insulin. Age increases fat metabolism. If growth hormone is going to prevent skeletal muscle and adipose tissue from taking up glucose, it needs to promote the availability of other substrates for ATP production. Growth hormone does that by mobilizing fatty acids, increasing their circulation in serum. I'm not sure about adipose tissue, but I do know that skeletal muscle loves to use fatty acids as fuel for energy production. Growth hormone's effect on increasing fat metabolism will limit the body's ability to also store fat while GH is active. Growth hormone is considered ketogenic because it enhances conversions of fatty acids into acetyl coenzyme A, so it's ready for the Krebs cycle in skeletal muscle and adipose tissue. Under normal conditions, with normal amounts of GH release, it's not a problem. However, too much GH can lead to excessive fat mobilization, creating large quantities of acetoacetic acid formed by the liver, leading to ketosis. Growth hormone stimulates bone growth. Growth of the skeletal frame is the most obvious effect of growth hormone. Growth hormone stimulates the growth of bone in two ways, by length and width. Growth hormone will stimulate bone growth in length until the epiphyseal plates fuse. Growth hormone will stimulate bone growth in width or thickness throughout one's life. Bone growth in width is also called oppositional bone growth. Growth hormone affects bone growth by stimulating osteoblast activity and increasing production and deposition of chondrocytes and osteocytes. Indirect effect of growth hormone on metabolism. Growth hormone stimulates the liver to produce 4 small proteins called insulin-like growth factors, also known as somatomedins. This IGF protein has similar tissue growth effects as insulin. This protein acts like a hormone in that it travels in the bloodstream. And unlike growth hormone, it is released slowly from the blood into target tissues. This slow release prolongs the effects of this insulin-like growth factor. It circulates for about 20 hours after secretion compared to growth hormone that only circulates about 20 minutes after secretion. Effects of the specific IGF somatomedin C. Somatomedin C is also known as IGF-1. It is the only insulin-like growth factor we will cover in this course. IGF-1 stimulates the cellular uptake of amino acids, which in turn stimulates protein synthesis. It specifically promotes translation by increasing activity of ribosomes. The most profound effect of IGF-1 is bone growth. Somatomedin C increases all aspects of growth. It increases the matrix by increasing number and activity of osteoblasts. It increases bone strength by increasing the formation of collagen as well. Abnormalities of growth hormone secretion. One of the conditions associated with abnormal decreased secretion of growth hormone is dwarfism. Dwarfism is congenital and present from birth. There are 2 types of dwarfism. One is caused by panhypopituitarism, which is decreased secretion of all anterior pituitary hormones. Approximately 2/3 of individuals affected by dwarfism are born with panhypopituitarism. With this type of dwarfism, body parts develop in reasonably appropriate portion, but at a significantly decreased rate. Individuals with this type of dwarfism do not experience puberty or develop sexual function due to lack of gonadotropic hormones. The other type of dwarfism is a result of growth hormone deficiency only. This affects about 1/3 of all dwarfs. If only growth hormone is affected, that means their anterior pituitary gland produces normal amounts of all the other hormones. Since their anterior pituitary produces normal amounts of gonadotropins, these individuals will mature sexually and some are able to procreate. Abnormalities of growth hormone secretion. One of the conditions associated with abnormal increased secretion of growth hormone is gigantism. Gigantism is caused by overproduction of growth hormone before growth plates close. This overproduction can come on sporadically or can be due to a tumor of somatotropic cells that develop prior to closure of epiphyseal plates and long bones. The abnormally high level of growth hormone causes rapid, albeit reasonably proportional, tissue growth of all body cells, especially bone. Individuals with this condition can grow up to 8 feet tall. Did you ever think anyone could make the Rock look small? Another condition associated with abnormal increased secretion of growth hormone is acromegaly. Acromegaly is caused by overproduction of growth hormone after growth plates close. This overproduction can be caused by an anterior pituitary somatotropic cell tumor or ectopic tumors elsewhere in the body that produce growth hormone. Development of tumors would have to occur after the epiphyseal plates of the long bones close. Since growth hormone causes oppositional bone growth, the bones in the individuals with this condition will become thicker, and since growth hormone causes growth of all tissues capable of growth, the soft tissues in individuals with this condition will continue to grow. The typical characteristics of a person with acromegaly are enlarged extremities, hands, feet, cranium, vertebra, tongue, liver, and kidneys. And kyphosis is often associated with this condition.